Sciatic neuropathy is a significant nerve disorder affecting the lower extremities, second only to peroneal neuropathy in frequency. The sciatic nerve formed by spinal roots L4 to S3 travels from the pelvis through the thigh, dividing into the tibial and peroneal nerves. Its unique anatomy and position make it particularly vulnerable to injury, especially in the gluteal and pelvic regions. This vulnerability is heightened by anatomical variations and a lack of protective connective tissue. In this video, we'll explore the electrodiagnostic features of sciatic neuropathy, drawing on 6 years of clinical experience to shed light on its causes, diagnosis, and implications for patient care. Sciatic nerve is the largest nerve in the human body, originating in front of the piriformis muscle and exiting the pelvis through the greater sciatic foramen. It then travels down the thigh, where it eventually splits into the common peroneal and tibial nerves. This pathway is crucial for leg movement and sensation. However, the nerve's posterolateral position and minimal connective tissue support make it susceptible to various injuries. Understanding this anatomy is essential for clinicians, as it helps in pinpointing the location and potential causes of neuropathy, especially when interpreting electrodiagnostic results. Sciatic neuropathy can arise from a variety of causes. The most common include direct trauma, gluteal intramuscular injections, pelvic or hip surgery, bone fractures, and even prolonged positioning during surgical procedures. Other less frequent causes are tumors, hematomas, autoimmune conditions, and vascular issues. Notably, the peroneal division of the sciatic nerve is more prone to injury, especially in cases involving excessive traction or anatomical variation. Recognizing these risk factors is vital for both prevention and effective management of sciatic neuropathy. Electrodiagnostic (EDX) testing, including nerve conduction studies (NCS) and electromyography (EMG), plays a pivotal role in diagnosing sciatic neuropathy. NCS evaluates the function of sensory and motor nerves by measuring parameters like amplitude, latency, and conduction velocity. EMG, on the other hand, assesses muscle activity and can detect denervation or reinnervation changes. These tests help localize nerve damage, assess severity, and distinguish sciatic neuropathy from other conditions such as lumbosacral radiculopathy or plexopathy. Proper technique and interpretation are essential for accurate diagnosis. Over a 6-year period, 58 patients diagnosed with sciatic neuropathy were evaluated using EDX at a major referral center. The study divided patients into pediatric and adult groups, with adults further categorized by etiology, injection trauma, non-injection trauma, and other causes. Pediatric cases were fewer and not subdivided due to limited numbers. This structured approach allowed for detailed analysis of clinical features, comorbidities, and the timing of symptom onset relative to diagnostic testing. Such stratification is crucial for understanding the diverse presentations and outcomes associated with sciatic neuropathy. Clinical presentation of sciatic neuropathy varied across age groups. In adults, injection trauma was the leading cause, while in children both trauma and postoperative complications were common. Drop foot was observed in a significant proportion of both groups. Electrophysiologic studies revealed that total sciatic nerve involvement was relatively rare, with partial involvement, especially affecting the peroneal division, being more frequent. NCS and EMG findings helped differentiate between types of injuries and the extent of nerve damage, providing valuable information for prognosis and treatment planning. Key focus of the study was comparing sciatic neuropathy resulting from injection trauma versus non-injection trauma. While both groups showed similar patterns in nerve conduction and EMG findings, non-injection trauma cases tended to have lower sensory nerve action potential amplitudes, suggesting more severe damage. The peroneal division was consistently more affected, regardless of the cause. These findings highlight the importance of careful technique during intramuscular injections and the need for heightened awareness of sciatic nerve injury risks in trauma and surgical settings. Accurate diagnosis of sciatic neuropathy relies on a combination of clinical assessment and electrodiagnostic testing. Differentiating between sciatic neuropathy, radiculopathy, and plexopathy is essential for targeted treatment. The study underscores the need for awareness of anatomical variations and risk factors, especially in routine procedures like injections. Early and precise identification of nerve injury can improve outcomes, guide rehabilitation, and prevent long-term disability. Ongoing research and larger studies are needed to further refine diagnostic criteria and management strategies, particularly in pediatric populations. Summary: this 6-year experience provides valuable insights into the electrodiagnostic features of sciatic neuropathy. Injection-related trauma remains the most common cause in adults, with the peroneal division being particularly susceptible to injury. Non-injection traumas may result in more extensive nerve damage. The study also highlights the rarity of pediatric cases and the need for more research in this group. Moving forward, clinicians should remain vigilant for sciatic nerve injuries, apply best practices in electrodiagnostic testing, and advocate for preventive measures in high-risk procedures.